Hi, everyone. We're going to get started for this afternoon. A couple of things. For those of you who are not on Instagram, you will notice that there's been some slides going with some pretty vintage photos of Britsman, some of them more vintage than others. If you haven't been here for the one with Britsman camping, it's quite, for me, a bit of a shock, but that's my favorite one. We will play these slides at the next break, and if you are on Instagram, you'll recognize some of them, but for those who are not, we thought we would share them with you. I hope you had a really great nostalgic pizza lunch out of those boxes. And we will move now on to our second panel of the day, which is on psychosocial studies in the clinic. And we are going to be moving until 2 p.m. And so Kathy Mitro is going to be the chair to take us there.
All right. Thank you, Lisa. This has really been a truly wonderful conference. And I'd like to take a moment to thank Lisa, Jen, and Aziz for their insight in conceiving this event and the tremendous work it has taken to pull all of it together, from funding to organizing and now running the 2 days. And of course, a huge thank you to Deborah Britsman for the fabulous keynote address yesterday and for being the inspiration that has brought us all together. Can we put our hands together for all of those, please? As we move into the final afternoon of the conference, our next event, as Lisa mentioned, is entitled Psychosocial Studies in the Clinic. And it's my honor to introduce the three panelists, Sheila Harms, Susan Searles-Giroux, and Oren Goslin. Our first speaker, Sheila Harms, is Associate Professor and Associate Chair in Education in the Department of Psychiatry and Behavioral Neurosciences at the Faculty of Health Sciences at McMaster University. Dr. Harms also practices as a child and adolescent psychiatrist at McMaster University's McMaster's Children's Hospital with a focus on general outpatient care. Dr. Harms' research focuses on the embodied qualities of therapeutic practice as experienced and understood by therapists working across a range of complex traumas. Following Sheila, we will hear from Susan Searles-Giroux, Professor of English and Cultural Studies at McMaster University. Susan is the author of several books, including Sites of Race, Conversations with Susan Searles-Giroux, co-authored with David Theo Goldberg, and Between Race and Reason, Violence, Intellectual Responsibility, and the University to Come. Upon completing a decade of service in senior university administration, Susan became a licensed psychotherapist. These shifts in her own career have informed her recent explorations in gender, workplace cultures, psychoanalysis, neuroscience, and emotion. Our third and final speaker for this session is Oren Goslin. Oren is a psychoanalyst in Toronto and a member of the International Psychoanalytic Association's Committee for Gender and Sexuality. His book, Transsexuality and the Art of Transitioning, won the American Academy and Board of Psychoanalysis Annual Book Prize in 2015. Oren is also the winner of the 2016 Simmons Prize, and his edited collection titled Critical Debates in Transsexual Studies in Transition was a runner-up for the 2019 Gradiva Award. Most recently, Oren won the American Psychoanalytic Association's Ralph Roughton Award in 2022 and the Canadian Psychoanalytic Society's 2023 Miguel Prados Prize. I remind everyone that we will hold questions until after each of the panelists has spoken, and I now invite Sheila to start off this afternoon's session.
Good afternoon to all of you, and I just want to start by saying what a privilege it is to be amongst such impressive scholars. Today I'm going to share with you some of my ideas that I'm working on from my book, which is part of Deborah's book series and is currently in press through SUNY. Methodologically, I rely on autoethnographic material informed by memoirs and critical texts. The thinking and writing of this book was largely conceived at York University through the work of my PhD here, where I had the profound privilege of working with Professor Britzman, as well as many others who are here today, including Alice and Lisa and others. Some of the material will be a repeat from yesterday, which I hope can be heard in a generative way and in an open way. Sociologist Willard Waller posed the provocative question, what does teaching do to teachers? Deborah also took up that question, and I have also shamelessly borrowed this line of inquiry and retrofitted it for my own profession, asking, what does an education in psychiatry do to a psychiatrist? And I've relied on this query as a way of organizing an interrogation into my own clinical encounters of learning. And today I'm going to specifically focus on 3 themes. The first theme engages the question of how the practice of psychiatry becomes an educational problem. The second theme has to do with bodies in psychiatry and what happens when they rub shoulders with a metaphorical group of people that I encounter daily in practice, and these are hospital people, the third theme that I'm taking up. And I'm viewing hospital people as an effect of the challenges associated with the medical establishment, which constitute the practice milieu I have both been educated by on behalf of psychiatry, and I've also survived. An educational problem is a problem of personal lack, according to the health professions literature, where skills or knowledge or attitudes are in short supply. But this definition of deficiency state didn't quite capture the transference dilemmas for me, otherwise thought of emotional situations, which we've heard a fair bit about, that seemed to take center stage when I was the subject of scarcity. I'm going to start with a brief passage from my book, which describes an encounter that frequently occurred in the early practice years and speaks to the idea of making psychiatry an educational problem. Tell the doctor everything. Be honest. We can't help you if you don't talk. I notice the way parents lean over their youth or hover around them as though to signal with their bodies that they mean parental business, serious business. And I actually have no idea what business they're referring to, yet I have a sickish sense about it. I wonder if this is the moment to get up and go to the printer outside my office door, just because. But I know I can't, or I shouldn't, so I don't. An urgency can be felt in the parental posturing and spoken words, registering more like a desperate plea or a stern command, as opposed to a casual request. Over the years, I have come to understand that there is nothing casual about this exchange, and that the clinical tips and tricks I have learned in training really had no place here. I perceive myself as an unwelcome visitor, a voyeur of sorts, watching a moment where the parent's tone suggests that the youth is being chastised about something they said or didn't say, but I can't make out if the problem is in the moment or having to do with something that has nothing to do with my office. One thing is certain. The parents are deeply suspicious of what will happen if the teen does not speak, and danger lurks, and I wonder who is it that is most afraid. Over the time, I treated my patients as I had been taught to do, but I soon learned that the promised cure of empirical, evidence-based psychiatry often fell short of the healing sought by all of us. The know-how in the custodianship of psychiatric care often and simply failed to translate into a show-how. And in these disorienting clinical encounters where it felt like where it was clear that something wasn't right, a pedagogical conundrum emerged for me that only belatedly registered as uncomfortable emotional symptoms about what I thought I had been taught to rely on. This scene and its dramatics is one of the reasons why Freud referred to medicine as one of the impossible professions, in its ultimate promise of dissatisfaction, where the limits of professional practice in relationship to those who engage on its behalf is also experienced by them. Frequently, clinical work for me resulted in outcomes where no one was happy, healed, nor repaired, but we were all affected by discontent. Britzman tells us that a profession like psychiatry is impossible because, quote, it proposes a constitutive discontinuity, a lack the profession represses, negates, and projects onto others, end quote. The pinpoint location of this disquieting unknown now becomes my educational coordinates of working through. Here, in the void, the idea of lack and tolerating uncertainty may just have the potential to be something other than a millstone around my professional neck in its invitation to enter into the unknown, signaling possibility and transformation over time, even though learning to practice often feels feeble and frenetic. However, fragility was not the image of the original psychiatrist. Some of the earliest accounts of psychiatry by 19th century psychiatrist François-Emmanuel Fodère tell us that the phenotype of a psychiatrist is a manly one, and we are introduced to a figure that will have a permanent arc in psychiatry. First, as a hero who will emancipate the psychiatrically unwell from the shackles of the asylum, and then later fulfill the role of the overseer of the asylum, understood in its contemporary form as the hospital administrator or a hospital person. Here, the physician-psychiatrist is not intended for therapeutics, directed at thought or feeling. Rather, the physician's power is called upon as a necessary active force to do battle with dangerous minds of patients whose sickness will relegate them to the status of an unwieldy subordinate, and it is the patient's body that will be managed by a psychiatrist's masculine physicality. When I engaged the question of what kind of bodies have constituted the historical work of psychiatry and how these observations might map onto gendered conceptualizations of my own experience, I have registered that the subject being spoken about is clearly not me. In response to this historical gendered exclusion, I may generously assume that Fodère was the product of his time in his proclivity for males to represent psychiatrists, and that time has indeed moved us into another space, more forgiving of myopic stereotypes, open to all genders, as well as the creativity implicit in diverse perspectives. But recent publications on the history of women in psychiatry came to the same conclusion that I am arriving at. When women were allowed as physicians, the data points to a psychiatric narrative relegating women to the custodial work of seeing patients and teaching, with limited experiences or representation in places of academic advancement or leadership which were otherwise normative for males. Education, more broadly speaking, has a penchant for custodial work, symptomatic of a troubling cliche. Britzman's Practice Makes Practice highlights the problem of persisting stereotypes in education that foreclose on the important possibilities inherent in discussions of gender and identity. She states, quote, in the case of women teachers who are merely seen to carry their natural abilities into the marketplace, they are apt to be characterized as either martyrs or idiots, end quote. How then should my body be in psychiatry? As an academic psychiatrist, education and practice would often paradoxically be experienced like vestiges of the sterile surroundings of the hospital itself, attempts to leave questions of diagnostics behind and work towards an understanding of suffering has repeatedly felt as though an educational or clinical undertow was present, making the hospital almost anaphylactic to its own directive for caring. It was like the hospital became a defense against the suffering it contains and acted as a giant place for denial. In his memoir, On the Move, The late writer and neurologist Oliver Sacks warned me about hospital people. Sacks was well loved by his patients and had experienced significant academic success. It would seem logical then to think that a successful physician such as Sacks would have been well regarded by hospital administration, but for Sacks, his clinical success was a liability, and in his memoir, we find Sacks continually at odds with an infrastructure that is intended to promote caring. I too had many dark moments with the confines of the hospital and with hospital people. Some experiences had to do with my own clinical errors, being publicly discovered and finding no gentle place to heed them. Others had to do with challenging calcified pedagogies or advocating for medical learners who, in my mind, were at the behest of a big, indifferent machine, relying on an education of service, while at the same time paying little attention to the meaning of an education of service. Other examples had to do with speaking up for patients in a psychiatric system that would commonly aggress against them. The examples I have shared became fused with the image of a physician offered by Fodor, mechanistic in form and static in presence, suggesting a type of relational deficiency that leaves an industrial taste in our mouths. In answer to the question then, how should my body be in psychiatry, I have a short story to share. I was recently on call and phoned by a nurse in charge about a homeless adolescent who was wanting to leave the emergency department. The patient had been to the hospital many times before, and it had repeatedly been a traumatizing experience for her. She wanted to leave and at the same time had nowhere to go. It was close to midnight when I got the call from the nurse, keen to demonstrate his knowledge about the Mental Health Act. He wanted me to know that the patient stated an intention to leave and that he had an ethical obligation to tell her what her various options were, including going to a shelter, being discharged to the street, calling family members who had already said that she was not welcome in their home, or calling in the on-call doctor to place her on a form, insisting on a short hospital stay because of safety concerns. All of the options did not sound like options at all to me. I found myself frustrated with the ineptitude or willful obstruction on the part of the nurse in managing a common problem in this setting with a relatively common solution. Of course, the teen wanted to leave the hospital. This was to be expected. A conversation is what it boiled down to. When I arrived at the hospital, I asked the patient for her permission to enter into her room. She told me that she wanted to leave, but sounded deflated and lackluster in her sense of urgency. She told me of being in the hospital at previous times, being bored, being locked into her room, and being afraid that she would never see her pet lizard, who was the only living being that gave her comfort at bedtime. I clued in. Tell me about your lizard. How does your lizard help at bedtime? He tucks me in, she said. He cuddles in beside my head. He tells me I am okay. She then shyly asked if I could tuck her in, like her lizard would do. I agreed and almost instantly was deeply uncomfortable in the moment, realizing I had potentially agreed to a response beyond an acceptable boundary. I wasn't quite sure how she would want to be tucked in. What if the need was too great? How would I be asked to use my body? She knew better than I did and told me it was only her feet that needed the blankets tucked around them. This is what her lizard would do. Although I find the idea of a reptile beside my head entirely repulsive, the youth had brilliantly conveyed to me what she needed, and I thanked her for having a lizard who was clever enough to instruct the doctor in finding good enough options for her. In conclusion, I returned to the question, what does an education in psychiatry do to a psychiatrist? Well, there is little doubt that the act of being worn down by chronic uncertainty, doubtful pretending, and failure, the narration of my clinical queries and educational conflicts underscored what it meant for me to be alive and in pursuit of an authentic, freer self, framed by the welcome shadow of an intersubjective relational space. And in this way, there was, and is an intense beatitude that accompanies my educational practice as a clinician.
Thank you, Sheila. And now if we could have Susan come up for her presentation.
Hey, afternoon. First, I have to acknowledge that I would not be here today without Deborah Britzman. This is a woman who wrote for my tenure. I still owe her for that one, and my full professorship, and was the signal inspiration for me going back to grad school and getting a degree in psychiatry and starting a practice. And to Alice, comrade in arms for 10 years in senior administration. We were vice provosts and provosts together and smoked a few cigarettes and survived it. My thanks to both of you. My clinical practice currently includes a number of clients who are part of Ontario's vast K-12 educational system. It is one of the most deeply satisfying aspects of my new role as a psychotherapist, given my experiences and researches in the field of education, and also one of the most disquieting, given the narratives I hear about the mounting institutional pressures, budgetary challenges, unwieldy parental expectations, and afflicted students and teachers. I will speak entirely too generally about this agglomeration of clients, in part to camouflage the particularities of identities, in part to adhere to the time I'm allotted. Suffice it to say, some are kindergarten teachers, others instruct much older students, and all engage students who are more and more presenting with complex special needs. Others are staff members who play essential roles in guidance counseling and HR. I also see members of its senior administration. Unsurprisingly, given the overrepresentation in primary and secondary education, they identify as women who range in age from mid-30s to late 50s. They have advanced degrees, and they emphasize how hard they have worked for their achievements. Many describe parents, sometimes even grandparents, who are also teachers, and they manifest a devotion to teaching and learning and to young people. In addition, they report they have families and attend to complicated care routines for their own deeply anxious children, children with severe allergies, children in usually several competitive sports. Many also have elderly parents who are infirmed, needing assistance to navigate the healthcare system or suffering the loss of a lifelong partner. They come to session to find relief for their racking anxieties, insomnia, fatigue, lack of appetite, migraines and body aches, neurasthenia. They also report emotions like severed, amputated limbs, anhedonia, numbness, and lifelessness. They explain that their work is constant, incessant, and impossible, both at school and at home. They describe to me the import of their professional responsibilities, not in a way that highlights self-importance. Their secret sense of incapacity, insufficiency, and incompetence would never countenance this, but rather to underscore all who depend on them. They tell me, or rather they reassure me, that they strive for perfection, even as they know, like all perfectionists know, that this is an impossible project. They love their jobs, they love their families too, but they also hate them. Many express rage and guilt for their rage, guilt for their fatigue, guilt for their shards of time they have to share with loved ones. Others say that they have no feelings, or rather they feel anesthetized, immobilized, and unresponsive. I am dead, one announced to me several times in session. This is not sustainable, they all say. I need more balance in my life. Yet when asked specifically what they would like to change, they can't fathom a single modification to a schedule that is their daily torment, as if to be relieved of their symptoms would be simultaneously to lose their lives. They live that time bind in which the social worlds of work and home have been reversed. Sociologist Arlie Hochschild explains that the more attached we become to the world of work, the world of doing, with all of its deadlines and disruptions and demands on time, the more family must accommodate the pressures of work. I'm reminded of Adam Phillips' comment that the modern search for balance is probably our most unbalanced moment. Listening to these clients, I'm convinced that balance is no longer a useful index for the lives we live. In this paper, I want to explore perfectionism, very, very imperfectly, to be sure. The first is in keeping with my still quite nascent role as psychotherapist, and the second is informed by my academic career, my disciplinary training in cultural studies, and my decade of experience in senior administration. In a developmental sense, perfectionism functions as a regulative idea and an unachievable, unrealistic ambition. The psychoanalytic literature has much to say about this question, which I will certainly not do justice here. I cite Adam Phillips again, who pithily summarized the problem as Freud imagined it. He writes, Freud's question was, how has it come about that human subjects experience his need as a wound, his desire as insufficiency? For him, the wish for perfection is an unconscious acknowledgement of the impossibility of repeating primary experiences of satisfaction, or acknowledging that they did not exist, that satisfaction is always lacking. Kleinians, he adds, would say that perfectionism is a form of mourning for the loss of infantile omnipotence, a derivative of the fantasy of self-sufficiency. An incomplete satisfaction, he says, is inherently involving frustration, a situation which, whatever else it entails, requires acknowledgement of incapacity. To be sure, my clients have no trouble acknowledging and suffering their incapacities, but Phillips, through Freud, writes that it is the capacity for incapacity that is required. I consider as I write this that I am no less seized by this culture of achievement. I have pursued the same aspirations as my clients, and I am learning, admittedly uncomfortably, in this very moment, to make room for my incapacity. So I continue to push my partially digested understanding. How is this feeling of incapacity, the collapse of self-sufficiency, of failed omnipotence, experienced in different bodies assigned to gender, and one that unleashes, for all sorts of historical, sociological, religious, and cultural reasons, what Britzman has called disquieting imagination. What Deborah Britzman adds to the conversation is a consideration of gender, even as she acknowledges its deeply troubled, unstable meanings in decades-old debates over essentialisms, constructivism, and evolutionary psychology. Drawing on Riviere and Klein, she argues that the most difficult things for the human is coming to terms with the fact of dependency and the overwhelming anxiety for the loss of the beloved object. We can now get to the punchline, she wryly observes, in that our originary dependency on the mother will have an afterlife in how men and women imagine, through fears of prosecution, punishment, envy, and with love, guilt, and reparation, the advent and vicissitudes of femininity and masculinity. I have pondered time and again this notion of the gendered afterlife of our fact of dependency, as I listen to women whose striving for career success and meaningful occupation, as well as autonomy and independence, has brought them to absolute nervous exhaustion and burnout, who navigate the impossibility of their profession and yet cannot bear the thought of an early departure or retirement without feelings of fear, dread, and helplessness. They mourn having to relinquish some measure of financial independence, but more so, many of them recoil from the destabilizing prospects of losing their primary alibi, their first defense against the demand for a return to more intensive and invisible care work, insistently and consistently coded as female, at home, babysitting grandchildren, or assuming part-time or full-time care of very elderly parents. They want to refuse becoming either the subject or the object of such dependent states. I invoke teaching as an impossible profession, not preeminently in the way that Freud describes it, but rather to mark a series of new conditions that have dramatically and negatively impacted the work of teaching. Some of these pressures are external to the sector. The enduring impacts of a global pandemic, for example, which have resulted in significant developmental delay in young children, have translated into myriad difficulties for their teachers, not least among them getting students to grade level proficiency, especially in a context of post-COVID economic and budgetary fallout. Other pressures have emerged internally. More recently, for example, a new vision of perfection has manifested and has dramatically reshaped the vaunted discourse of managerialism, bolstered by its own empirical measures and benchmarking metrics, in keeping with the relentlessly competitive dynamics of a global economy. In this perspective, perfectionism is no longer a distant horizon, but a goal that can be entirely achievable by means of the right kind of activity. Further, according to this logic, if a goal can be reached, and make no mistake, the goal must be reached, then it follows that it can be exceeded over and over. This is the dream of optimization, the fantasy of continuous improvement and maximized efficiency, which encompasses ever-expanding areas of economic and social life. This is it, right? I can say with profound shame, I peddled this horseshit, right? So pervasive in its reach that its pressure to optimize has been internalized in the quest for constant performance enhancements and improvements of self. We become experts in self-supervision. Alain Ehrenberg explains, in the former discipline-based era, the aim of institutional regulation of work or behavior was docile, obedient individuals whose individual choices and initiative were wholly subordinated. In the new flexible, autonomy-based system, the aim of regulation is precisely personal initiative, with an emphasis on social and emotional skills related to increased self-control and improved self-conduct. At the level of educational systems, perfectionism mutates into institutional mandates that must be fulfilled and then immediately and repeatedly transcended. In, for example, constantly improving reading and math proficiencies in K-12, or economic impact factors at the university level. For Ehrenberg, the consequences of the shift from discipline to autonomy is a demand for increasing capacity for both emotional self-expression, self-control, and self-management. At the same time, our social relationships are more and more articulated in the language of affect and emotions, distributed between the good of mental health and the bad of psychic suffering. Optimization is, in short, an administrative imposition that will certainly reward the kinds of obsessional behaviors it endlessly mandates, just as it will punish the obsessive symptomology it also prompts: anxiety, insomnia, exhaustion, depression. Thinking back to my clients, I want finally to table an additional cost that women in pressured service sector fields like education pay. Professions which, due to overwhelming new pressures, require more and more emotional labor to assuage frustrated parents and overreaching administrators, to say nothing of deeply dysregulated children. Defined by Hochschild, this is labor that requires one, quote, to induce or suppress feelings in order to sustain the outward continence that produces the proper state of mind in others. In this case, the sense of being cared for in a convivial and safe space. Both men and women perform emotional labor, she says, but women are expected to do much more of it. Hochschild theorizes the risks that workers across the service economy take in being continually alienated and estranged from aspects of the self, given the requirement to coordinate action and feeling, to manifest the appropriate emotional tone, the performed authentic emotional sensibility, so that the work appears effortless and therefore also invisible. As emotional managers par excellence, women comply with feeling rules and learn to follow and reinforce emotional convention. To show that nurturance, patience, and encouragement in the classroom take any effort at all is to perform the job poorly. Of course, educators are keen to create the pedagogical conditions in which learners can thrive, but this often means having to disguise fatigue, irritation, resentments, and frustration in the interests of an artificial elation. Considering the costs of this expanding repertoire of emotional work and the attendant alienation from authentic affect and emotion, Hochschild ponders the degree to which women especially are able, at the end of the day, to listen to their feelings and indeed experience the very capacity to feel anything at all. In her reflections on gender madness, Britzman writes, I imagine that worries over depressing our students with the discussions of gender continue to this day. In a similar vein, I wonder whether and how to address the specifically gendered and complicated and fraught conception that this is, consequences of perfectionisms, and and the risk I take in depressing clients with my observations. As Britzman states, I have also felt it is difficult to know when we are not talking about gender. Thanks.
Thank you, Susan. And now if we can have Oren come to the podium.
Good afternoon. Can you hear me well? Okay, good. First, what a great honor and pleasure to present at an event celebrating my beloved friend Deborah Britzman and her profound contribution to the field of education and psychoanalysis. Beyond our close friendship, Britzman is a mentor whose thinking has contributed and shaped significantly my own thinking, my own growth personally, as an analyst and as a writer. You will recognize her strong influence in all of my writing, including this one titled Narrative Revolts as a Creation of a Self. Britzman describes a temporal dilemma in education, quote, the profession too must depend on an autonomy that does not exist for both the profession and those served. Education, she suggests, come as an after effect. One must assume creativity before it is known. I lean upon Deborah Britzman's capacious conceptualization of learning as a potential space between knowledge and its limit to think about this temporal difficulty that also belongs to gender. And Britzman's work helped me to knock on the door of absurdity in the structures of gender. In my previous work, I was interested in gender and transitioning as a question of aesthetics and art, by which I mean the conceptualization of gender as an artful project, the art of creating the self. I turned to art, film, and literature to imagine transgender as a psychical experience, as a question of representation, and as an enigma that belongs to gender. Today, I want to take a fragment of these experiences and move it to an understanding of different situations of transitions, gender transition, and that are grounded in gender, but that suggest a wider world of experience, with the claim that the self is a complicated matter, but its complexity comes at a surprise, because in trying to understand the self, we meet its inaccessibility, like the dream's navel. What I'm trying to show in this paper are these complications in the attempts to write about them. What is interesting to me is the question of what we can learn from the study of people trying to talk about their lives via memoir. The immediacy of the arguments over gender and gender transitioning we encounter today, I propose, might take a different turn if we look at different ways of conceptualizing transitioning. For a better grasp, I'm going to be juxtaposing two memoirs of gender transitioning, one from the vantage of a person who has transitioned, and the other from a perspective of a witness to transitioning. The memoirs share something in common. They give the reader a sense of transition as a human condition, not an exception. I read them as narrative revolts. The narrative accounts are brave in a sense that they resolutely face the foibles of not knowing and the anxiety of needing to know. They open gender to the challenge of origin, the quest of an even history, the traditional notion of identity and development. Novel conceptualization of gender and transitioning also offer us original metaphors with which to consider new ways of listening to gender as a borderline concept that cannot be traced to biological or social causes. It is shaped as it is narrated. One way of staying with the question of gender is through thinking about the difficulties of articulating it. Part of the difficulty resides in the strange temporality of gender. Making sense of gender is a process ruled by the temporality of afterwardness, that is, something that can only be interpreted and made sense of from the position of the present, for which the case of reading becomes exemplary. I approach memoirs as case studies, following Forrester's insight that in reading clinical cases, we can begin to conceptualize our own theory of reading. The writing of a case, Forrester suggests, is already an after effect of the transference, and this combined action of, this is a quote from Gallup, combined action of anticipation and retroaction is essential to how and why we write clinical cases at all. In writing cases, we are confronted with material that does not fit together until we bring an Nachtraglichkeit, afterwardness, temporality, to bear on the case, thus revealing the meaning of disconnected bits through the deferred action of writing. This retroaction, Britzman suggests, become, quote, a means to revise and construct the impact of experience left before understanding, end quote. Cases for Forrester are exemplars, not because they can be generalized, but because they present a threshold. Cases give us access to social, political, emotional, and pedagogical situations. A 50-year-old acclaimed theater producer, P. Carl, decides to undergo gender transitioning. He is now a man who enjoys a free pass into misogyny, a sudden privilege, as he calls it, of joining in belittling jokes about women and the, quote, power that emanates from them, from his white male skin. But at the same time, he experiences guilt. His is a text about the impossible attempt to put history together. In the process of transitioning, his understanding of himself transforms. P. Carl writes about a sobering change in the way he is now addressed by others. There are those who retract or attack, others who disregard or welcome. His retroactive look at his pre-transition self, who he now experiences as his twin, also invokes in him questions about his capacity to hold on to parallel realities and versions of self. As long as P. Carl feels that he has to prove his gender to others, he is caught in the image of a macho man, in the elation of hormones, in the pleasure of the body, and in being seen on his own terms. There may be a terrific pleasure, a beautiful feeling of being part of something much bigger, the world of men. But there is also something surprising that P. Carl finds. The cosmetic of gender, shaving, muscle building, climbing, are short-lived. What he faces after transitioning is the destiny of his aging body. Simply because he ages, gender is also subject to time. At some point, P. Carl must also face his partner's breast cancer diagnosis. Jolted by a friend who doubts his capacity as a man to understand his wife's condition or support her, P. Carl realizes that emotional situation of gender as destabilizing and conflated. He is beginning to experience the way men are seen, realizing that there is no such thing as a man, but a polyphony of masculinities at stake, where conflicting positions are constitutive qualities of gender. When a body faces death and a health crisis or loss of freedom, he asks, are there only women and men? As long as he could focus on transitioning as something outside of other events such as illness, age, and the shifting attitudes of friends, P. Carl could live in the ways in which his sedimentation of gender could hold in. But the encounter with these events presented a crisis, not only because of the emotional difficulty they pose in the present, but also because his ways of understanding his history has been transformed. The narcissistic preoccupation with the body, in a sense of the ideal image, shifts to an understanding of gender as a relationality. His question, how do I become a man, transitions to a more fundamental question, one concerning the pleasure of being and becoming who he wants to be, not only as a trans man, but also as a human. What kind of a man do I want to become? Through P. Carl's transitioning, the reader encounters gender not as a thing in itself, but an axis of innumerable relationships. Becoming a man is an explicit account of psychic change through an encounter with something far away from gender, but related to it: illness, excitement, sexuality, and relationships. Gender is never a discrete event one undergoes. Rather, gender can be thought of as an extension into life's experiences, both accidental and chosen. In P. Carl's account, beginnings are overdetermined and their narrated trajectory takes the form of a dream. Encounter as it is crafted. Narrating, reading, and writing structure gender's time, and we can say that its deferred in temporality not only expresses sophisticated trajectories, but also machinations. Meaning is in translation. Where do we narrate from when we witness the others transitioning? This is a persistent dilemma in Susan Faludi's memoir, In the Dark Room. Faludi, a journalist and a feminist activist, grapples with gender transitioning of her estranged elderly father. The transitioning of her childhood father from a violent man into a delicate woman was a personal event that created a new frame of thinking for Faludi, a woman whose lifelong contributions to the feminist movement exceeds her crucial coinage of the term rape culture. The new frame meant that the old frame could not be universalized. The macho, aggressive man she remembers from her childhood is now a woman who goes by the name of Stephanie, who wears high heels even while hiking, and who insists on being greeted by being kissed on the hand. This transformation is shocking to the author, who wonders, is my father's transitioning a return or a departure? At the core of Faludi's current inquiry is not a physical violation, aggression, or rape, but rather an entrance into something less delineated, more enigmatic, and unfinished. A relationship and a loss. In the Dark Room bears witness to the author's own transitioning, a transformation of her relationship with her old self. What unfolds in her memoir is an attempt to make meaning of intricate family story whose traces she is compelled to examine anew, if only to discover that she is still, or again, unable to capture or undo history. Faludi movingly examines her own transformation, and she revises her relationship with her estranged father as she witnesses her transitioning in the context of a longer history bringing her to Hungary and to his Jewish family during World War II. There's a dimension of the father's transitioning that positions identity close to a kaleidoscopic notion of escaping. Her father is an escape artist. He had escaped Nazi regime by disguising himself as an SS officer and succeeding in outwitting the Germans into releasing his parents from captivity. He escaped from his parents, his native Hungary, his wife and his daughter, his Jewish identity. his criminal past, and finally, his masculinity. The ego, however, cannot escape itself, and so, in her attempt to discern the many faces of her father, Susan Faludi's memoir also leaves us with a question: what remains after transitioning? Against the backdrop of Faludi's reassembling her relationship with her transitioning father, we witness a complex scene of history that is bigger than the history of the body. It includes the history of older generation, of war and anti-Semitism, of hiding and taking space. History here functions as a site of doubling, deferral, contradiction, and enigma. There is no clear before and after, only an elusive and intermediate space of uncertainty where the past is never past. There is something in gender that resists cohesion, revealing an uncanny quality. Quote, "My father fusses with her scarf and then leaned over to deliver a strange whisper into my ear. I know what what they're thinking," she said, sotto voce. There is an overdressed shiksa." What starts as a daughter's attempt to remember her childhood and make sense of her absent father's gender shift becomes a question of how one lives with uncertainty. And here, the reader is doubly affected. Transitioning produces new editions of old conflicts. In witnessing her father's transitioning, Faludi is also creating something new. The easy narrative of a violent and neglectful father is now insufficient as she confronts a larger and more complex psychic landscape, one she is not in control of, and that forces her to revise the history of her own attachments and disidentifications. Eventually, Faludi shifts from the study of biographical events to a study of how people make sense of their experience. In the process of attempting to understand her father, she gradually moves to trying to simply stand him. The process of excavation of historical details turned to one of interpretation. She enters something much more enigmatic than the tracing of cause and effect, and she comes to see identity itself as an obstacle course where the truth is elusive and ever incomplete. What the reader enters with Faludi is a surrender to obscurity. The surrendering in writing and witnessing also applies to gender transitioning. One must wait to see what unfolds. With each story of transition, we encounter the way in which the author is pushed to reimagine their own psychic landscape, and what the memoir shows us is the way in which transitioning are also transformations in relationality. It's not simply an individual transformation, and the transformation, as a memoir shows, is not immediate. It is a process that is overdetermined by situations that cannot be anticipated, such as the other's response. Even relationality, one comes to see, much like autonomy, must be assumed before it is created. Memoirs open the dilemma of fate, the aging of all the grand markers of bodily identity, and the fact that the body is always in transition, no matter what you choose and whoever you are. But this uncertainty is also a condition of desire. As we transition, we are already transforming in ways we cannot predict. What can the analyst learn from reading memoirs of transitioning? Memoirs of gender take us outside of what we know. By reading memoirs, I'm entering a world that is both mine and not mine. It is a way into an imaginative world that allows us to enter us into conflicts, questions, and representations of being in the world. With a depiction of the entanglement of gender in conflicts of recognition, reparation, reconciliation, revision, we receive a vantage through which we can appreciate the difficulty of conceptualizing gender, even though it appears to be very present. Through the memoirs, the reader begins to see that people change their understanding of themselves because their circumstances are in flux. My discussion on different narratives of transitioning opens up some of the dilemmas that have been foreclosed when the phenomenology of experience is set aside. The attempt to grasp a situation by observing the terms and moves of libidinal life, places of enjoyment, defenses, performances, are an ethical term, as Britton suggests, towards human events. If we think about gender in this enigmatic intermediate way, we will be able to enter the crevices that our previous theories foreclosed and the full range of experiences and people that participate in gender transitioning. To describe gender, as Britzman does in her paper on the madness of gender, as a situation that is both affecting and affected, is also to point to a temporal difficulty that bears on the question of freedom. The situation of gender is oriented by an agency one cannot possibly know, because the agenic self is always already changing through the very exercise of its autonomy, which transforms any notion of autonomy related to decision-making, whether to take hormones or undergo surgery, into something one has to assume in order to make it exist. The ethical position of the analyst entails negative capability, because what is put in doubt is the conceptual framing of listening. It does not matter what we know when we listen to the other. Here, ethics is not to be assumed, but something that is anticipated and configured in the condition of learning and in the therapeutic situation. The anticipatory and delayed situation gives the notion of identity its creative potential. The process of transition already suggests a change, but its experience can sometimes feel seismic and sometimes as a fault line that is susceptible to something that is unimaginable. And yet, memoirs are also a way of grappling with the unimaginable. The transitioning of an aging abusive father into a delicate woman, the coming to terms with limits and death, the question of choice that involved in the dilemma of being and not being, life or death, and of livability. In what body do I want to live in? Gender is glimpsed through its vicissitude as a performance, a space of creative self-configuration and self-expression, as a defense against a regeneration of a lost object. And while I may understand the meaning an individual gives to their gender, gender itself remains mute. History is indeed difficult for the psyche. But then, Britzman suggests, there is another side to this dilemma. Psychical life is difficult for the telling of history because, she says, part of the psychical life is unconscious, and the unconscious is timeless, something that history cannot be, end quote. We cannot cut off our history because our history is also a cut. An otherness that determines our psychic susceptibility to interpretation, elaboration, and creativity, so that a new note can be made from everything that is accrued in fantasy. To witness transitioning one's own or other and others is also to create a narrative of what it is we see. And in this process, we confront a temporal dilemma. In attempting to understand, we also step back, lean on familiar coordinates, while something new is reconstituted through the weaving or historical narrative. The process is always already marked by the present. Through the notion of Nycreglish temporality, development, and hence one's experience of gender becomes one of proximity, of contiguity, and meaning-making made through experience of pleasure, pain, illness, abuse, and care. All these register in a particular way, and our libidinal investment in them cannot be predicted. It is the dreamy quality of the narrative's temporality, its retroactive function, that I explore as a criteria for psychical elaborations. What we are seeing through each of the memoirs is also something inaccessible and enigmatic. What I witness in Memoirs of Transitioning is an emotional situation of gender, not as an unveiling of something hidden, but as a way of creating a livable space for the self.
Thank you.
Thank you, Oren. I now ask Sheila and Susan to join us up here for questions. Okay, and the call goes out again for questions. I'm getting used to the silence. Excellent. Patty.
This is for Sheila. First of all, I want to make sure I heard you right. Did you talk about intense beatitude?
Yes.
Well, my question then is, how do you get it?
I didn't include an entire chapter that takes place in Uganda, and I've been teaching there since the early 2000s, and I'm on faculty there. And it comes back to many of the themes that were offered yesterday. I mean, you can imagine I'm on faculty in psychiatry in a place where I'm presumed to know something, but also know nothing. And you can't ever know nothing as a psychiatrist in your own setting. You're always a student with an expectation to be someone that you're not. And when can you ever let go of that? And so in my time in Uganda, the beatitude came from a profound emptying where I could let go of the idea of being an expert and could enter into a place of not knowing, and a knowing that was not a place of anxious departure, but that eventually went to a place of generativity where I could noodle around there a little bit and say, okay, what does this feel like? What is this like? And finally let go of the brittleness of a professionalism that was often very suffocating, if that makes sense. Okay.
Thank you for all of those papers. I have a question. This idea of transformation of relationality sticks with me, and I think it applies to all three panelists. So I wonder, I think this is an aesthetic question, but I wonder when we tell stories from the clinic, how you think about the narrative structure of articulating encounters with a patient or a client, and how the shifts in the narrative, the formal shifts in narrative structure actually contribute or relate to transformations in relationality in the treatment itself.
Speak a bit to that. I think the conditions, one creates a condition, or the capacity to create condition where you're not just listening to the narrative as a given, but you're listening to, in a way, a group psychology. You're listening to internal object. You're listening to condensation. So even when it's not as if, for example, in working with gender, you're not listening to gender. You're listening to a point of condensation of so many different things, and it's a kind of a dreamy listening. Has a structure of a dream, and that also moves the patient to think in a particular way when you're not just answering questions or asking questions, but you pose enigmas. You push in a certain way, not push in a directional way, but you're trying to associate yourself to broaden your kaleidoscopic frame of what it is that you're listening to. And you don't know what you're listening to. You always keep that as very tentative.
I can give you a very practical example, and it kind of stems from the opening of that "Tell the Doctor Everything." And I can tell you that many of the students that I have seen in training now, I can feel the eye roll, where it's like, wait a minute, my job isn't to listen to stories, my job is to diagnose. Your story isn't going to be helpful to me. Just let me get to the point where I can then prescribe. And that's an important, I think, point to arrive at, but it's so obvious that a conversation needs to happen. And so when you talk about, would you say a structure, a narrative structure? I'm not sure if I'm interpreting it correctly, but in the practical world, it really is departing from the clinical, or the symptomatic paradigms that foreclose on conversation, where you actually start to talk about suffering. Tell me about your lizard. Tell me about what your lizard does for you. And again, you're not going to hear that in or read that in any psychiatry textbook, but I think it is opening to the fragments or the condensation of imagination that brings you both into suffering but into the moment that is the clinical encounter, if that makes sense.
Yeah, thank you for the question. Is this on? Maybe. Okay, good. I struggle with that. This is the very first time that I've been asked to speak as a clinician about my experiences with clients. So what I can say is that I'm always cognizant of the fact that I am not a pedagogue in that room, and I have been that for 25 years. So it's always a question of how I learned to listen. And I can say that the experience has informed both my clinical practice, because it requires, a listening, a different kind of relationality. And I always thought I was a good listener in the classroom, and no, it's a piece of shit listener in the class. I just couldn't wait to chime in with and I had to learn, sometimes digging my nails into my palm to shut up and ask questions. And because I can get too clever for myself. I can think I know things that I don't, and I've had to, and I fail at it, but I've had to learn over and over again to ask what I think are obvious questions when I think I know the answer, only to realize I don't. Yeah.
I have a question that's directed at Susan, but if I can get it out, maybe Oren can also respond to it. I'm trying to think about, Susan, your discussion of the question of perfection, and particularly the way you transition it into optimization. And I'm thinking about post-enlightenment discourses of the perfection of the human and its obviously ongoing failures. And I'm thinking about how you deployed this notion of optimization in relationship to the recall of your time as a provost and vice provost, and and I didn't get the line. I didn't write the line down, but you can meet the goal and then even exceed it. And it seems to me that in each moment of that kind of optimization, in the context of the university as institution, it's occasioned by a moment of failure. And so, what does it mean to optimize and to produce the perfect moment of having met the goal that is a failure for so many others after? I was wondering if you would reflect on that some more, and because it seemed at one point that you were, maybe this is too harsh a word, that you were refuting your time as a provost. So I'm curious about that. And similarly, I was thinking, Oren, in relation to this question of perfection and optimization, to think about transitioning as a kind of failure to achieve some kind of desire that keeps slipping. So I was wondering if we can have a kind of cross conversation about this moment of perfection and optimization and what it means for the social and the psychic.
So yeah, it's a great question. I wanted to kind of come at this question of perfectionism, acknowledging the pressures, that we place on ourselves in our internal worlds, but then also an intensive pressure that we experience externally, especially in institutions that. And educational institutions, I think, at all levels are increasingly subject to a kind of oversight and accountability by an increasingly skeptical public that wants to see, in the clearest ways, what they do and what they achieve, and it means that you have these fantasies of productivity that's measurable, and that the resident intellectuals are accountable for. And as provost and vice provost, I can say over the course of my 10 years there that you see this overwhelming spread of mandate, right? It's not just that universities are responsible for the life of the mind and that kind of older discourse, but they have to train workers for an ever disrupted career landscape. They have to anticipate AI. They have to train workers to be a step ahead of obsolescence. And they have to stimulate the economy, and they have to provide answers to wicked questions, and they have to deal with the mental health of students and educators. And increasingly, and of course, it goes without saying that the budgets are always shrinking as these impositions are accumulated. And so faculty fill out these activity forms, and they're egregious. They're filled with white space, and everybody feels moldy and useless after the exercise of filling them out, because there's so much expectation and only so much of us. So I began to think, because I was in charge of faculty professional development, and as I stepped away from that role and entered into literally a psychiatric hospital to do my practicum, and I'm thinking about the harm that level of demand, that incessant, ongoing professional demand places on individuals, how little room it leaves for them to be anything else, but also how insistently and creatively faculty would punish themselves for not achieving what was finally impossible. So that's always been, what I've been thinking about. Certainly, what I hear from clients who are still in some field in education.
Well, in relation to gender, there are a couple of things to think about. One is the work of disillusionment that is very much a part of what people who come to the treatment in general, struggles, will have to come to terms with the limits of their situation, whatever it is, but particularly in gender, in a very particular way. Also, the gap between the body and its representation. There's always a failed attempt to close the gap, and gender is one attempt to close that gap. And so there's always a failure. And how is it dealt with? It's just mourned and in a sense of attempting to find a way to live. It's a way of trying to find a livable space for the self and surrender to limits that are unavoidable. But again, as many of the presentation here touched upon, the creativity, the creative aspect of finding a middle ground, in a way, between what's possible and creating something new.
Sorry. So sorry for the chatter back here. This was just in reference to Ronaldo's question. I thanked him for his question because I, first of all, felt really called out by your paper, but also now very affirmed by the answer that you just gave. So thank you for that.
Thank you, panel, for your thought-provoking papers. I think probably each of you could speak to this, but I've been sitting here thinking about the situation of having trained at a psychoanalytic institute and being surrounded by doctors and psychiatric residents and psychiatrists who find their way to psychoanalytic training slowly, because they eventually realize that what I'm doing is useless. It's failing. I'm failing the people that I see. And I just wonder, about the kind of psychic toll on a professional who sort of goes into the profession with this sense of knowing something and expertise and being very capable in the prescribing and diagnosing kind of way, and then realizing something's missing, and whether that resonates with your own experiences. But what I found is it was really great to be in class with those people a lot of the time, because they'd come up against their own limitations in a really interesting way, and that was kind of the point they were starting from.
I can tell you that in the training, at least the way I understand Canadian psychiatric training, and I've been in levels of education leadership for quite some time and intentionally left that leadership space for many of the reasons that Susan was talking about. Increasingly, I mean, I write this in my book, that any reference to Freud now in psychiatric training is generally, it's an avenue into making jokes about perverted old men, really. And so there isn't a lot of rereading or ideas of generativity. There are some places for sure that I think are open to psychoanalytic training. But I think one of the moments that I realized that there was an emotional life happening was that not only the training failed, that somebody had to pay. And so now I find myself angry at parents, angry at patients. Why can't you just get better? Why can't you just do what I'm telling you to do? Because the evidence tells me that this is supposed to work, but then it doesn't. And so stuff is falling apart all around me. And so that was one of the moments where it was like, I can't be angry at my patients. That's not my job. In fact, my job is the opposite. So I think that was one of those moments where, like, okay, there's got to be a different way of looking at things. And I mean, paradoxically, you will be hard pressed to find psychiatrists in training now who are even alive to the idea of emotionality or an emotional logic that is at play that might depress people. But and so this was very enlivening for me to find a different way of thinking about psychiatry, paradoxically through the eyes of Freud and his colleagues. Yeah.
Thank you for your papers. I'm just kind of curious as well. You're all talking about that space between knowledge and not knowing, and how to stay in those spaces. And I'm wondering how you resist, even with a psychoanalytic frame, of not interpreting. Each of you has presented an interpretation, obviously, of your material. And so I'm wondering, how do you keep that space open, and how do you keep those conversations that you've talked about as conversations open and alive, so that it doesn't get shut down by a psychoanalytic theorizing, which we all bring to the table? I'm just kind of curious.
It is very, very hard. It's not a once and for all. It's an ongoing dilemma, of course, and there is a borderline space where you hear something, and sometimes patients cannot tolerate anything but a literal response, which may be at a particular time, at the very beginning, at the way of containment, a way of approaching something. But then you pull back. You try to dream with it. You try to listen to it as a dream, literally, to say to yourself, whatever the patient says, you say, okay, I imagine that the patient is telling you, I dreamt blah, blah, blah. How does that sound to you when you're just listening to it this way in your head? You may also allow yourself to just associate to anything. Sometimes, you disconnect from what a patient tells you, and your thoughts wander away, but there's a reason for that. So you're but there's always a miscommunication. There will always be failures. There'll always be misinterpretation. I mean, that's the condition of, that's how change occurs. In fact, it's a tolerating that kind of the difficulty of not listening literally, but also the seduction of listening to something in a literal way, and being the helper, the rescuer, the beloved breast, It is a very
Don't
difficult.
crush that for me.
And reading novels also helps, as Brittany recommends.
I almost never invoke expertise in the clinic. The rare occasion that I can think of, I might I think emotional labor in part because I was in clinic last night thinking about this morning, thinking about the paper, and I had a woman who is an educator, but it was at the end of session, and she asked me what I was talking about, and so I described what emotional labor is, and my reading of her reaction was that there was a kind of relief that there was a term for something that she felt pulled by, that and relief that she wasn't just like schizophrenic, you know what I mean? That there was like an institutional mandate for her to perform this kind of cheeriness when she really felt like she was dying, But those occasions are really quite rare for me. And going back to the prior question, my experiences with Sheila, like I was trained in a very, very empirical program where, Freud was shunned. The unconscious was not admitted. I had to use the euphemism outside of awareness, without otherwise getting in trouble, right?
Yes, be careful about scratching your head. I'll think you want to.
There's been some talk of breasts here that we have the bad breast and the much loved breast. And I wondered if it's tied to what a friend and I came up with in terms of the working against the big tit theory of feminist pedagogy that we were sort of trained in as teachers, how to be responsive and loving and there for our students, and our refusals as we move through our careers to adhere to that role. And is that kind of what you're talking about when you talk about the bad breast or the loving breast?
It's the breast in the mind of the patient that I'm talking about. It's not the breast.
Let's be professional here.
It can also be an attacking breast. It could be, it's an enigmatic object.
Takes many forms.
Yeah.
Are you sufficiently answered?
No.
No. Yeah. Say that out loud. I'm going to come back to Sharon's question. Maybe I break all the rules. Well, I do. And I intentionally break all the rules now. I'm going to come back to what I hear often. I now primarily work in emergency psychiatry. So I'm primarily seeing young women who come in. They identify as young women. And the trope that they are telling me is basically what Susan has described, what the women at the end of their career. In other words, tell me I'm not crazy. Is this actually happening to me? And a lot of my work is actually giving voice to what their affect and what their emotion is telling me. And one could say to me, honestly, I'm going to challenge you, Sheila. Are you being the good breast? Are you being the emancipatory psychiatrist who's coming in to make it all better? But one of the things that I am seeing, and I think it is a cultural phenomenon, is younger and younger girls are being diagnosed with borderline personality disorder. You don't know what you feel, you don't know what you think, and so you better not speak. So all you can do now is act it out. And so a lot of what I'm trying to do is bring it back to word and say, this is what I think you're saying to me. This is what I think you're describing to me in terms of your emotional experiences. But you tell me, is that correct? And so bringing it back more into a sort of relational space. So maybe I'm being a good breast. Maybe I'm being a bad breast, I don't know. But for me, it's about, I think, emancipating an affect that is completely, an emotionality that is completely legitimate, but also aggressed and antagonized outside, on the outside for many of these young women. That's just one example.
And what about you within the context of being a higher ed administrator?
There's definitely bad breast. There's no question.
We're gonna make you a T-shirt. I was the bad breast.
No, and I have to. I'm having trouble kind of disassociating my understanding of that from a very Winnicottian discourse, and it's really about our ability to withstand the frustrations and the aggressions with whomever we're speaking. Clients, in some ways, with clients, it's the opposite. I can tell that they want to have a solid, strong relationship. They want me to like them. Students, on the other hand, not so much. And you have to tolerate, I think, I find that I have to work at the relationship much more in the university. I mean, I find I have kind of I'm at a kind of chiasmus. I have my sane conversations at the clinic and my less sane ones at the university, right? Yeah, I don't know. I'm still thinking about this.
Well, I think the best breast to be in the clinic is the thinking breast, which is goes to what you said, both to Winnicott and to Beyond, the integration of the good and the bad, the capacity to withstand the ruthlessness of the patient, the ruthlessness of the attack.
I have a question. We have time for one more question here. Okay, so please.
Last week I was on a website, and it was by a website focused on, how do you pronounce it, Deborah? O'Shaughnessy? The psychoanalyst Shaughnessy?
Shaughnessy.
And it was Shaughnessy? Shaughnessy? And it was a patient of hers who was expressing a lot of frustration at the analyst's writing of her, and was kind of feeling having been used and violated and also misinterpreted, and thereby thinking that the whole psychoanalytic experience over a period of years felt like a betrayal. And I wonder if you might speak to this in terms of the ethics here, briefly. What are your thoughts?
It is not uncommon now to have young people come into the emergency and say, Dr. H, I think I have X, whatever diagnosis it is. I think I have autism. I think I have ADHD. I think I have. And it's interesting that writing that narrative doesn't feel like betrayal, but the what's being described otherwise does. So in some ways, I think empiricism saves us a little bit, because you either buy in or you don't, and if you opt out, there's no real recourse other than to say. And so I think in some ways, psychiatry might have a different experience with that kind of betrayal. There's many ways in which psychiatry betrays its patients, don't get me wrong. That's quite obvious. But I think as a psychiatrist, the betrayal would be in not listening to the suffering that then necessitates the patient to go to a psychoanalyst. But that piece is very interesting. And I'm also not surprised to hear that.
Yeah. I don't know that I have much to add to that. Again, I've not had beyond today, I've not had the opportunity to think about, like, if I hadn't, because I have so many clients and was thinking of many I had seen over the course of a couple of years, and, I suppose one would, if one were to publish something, which I take to be the point of the obvious ethical requirement would be to get that person's permission if you were using like a case study. I think, speaking just generally, I don't know.
The interpretation wasn't agreed upon.
Yeah. No, this is challenging.
Efforts at anonymity, but the patient can tell from the details.
I'm not sure I understood the question. Is it a question of confidentiality? What was the betrayal? Just the interpretation of the work of the analyst?
Just the question, I guess, of ethics, in the sense of just wanting to hear your thoughts of how you might respond to this patient who
It's a patient.
is a patient, yeah.
I see.
A patient of hers who was in analysis for many years, and then later on read the interpretations and felt used.
It's very hard, because I would first think about it in terms of the fantasy of the patient, not the literal ethical question in that sense, but of course there is that too, but I would think about it more as a psychoanalytic question, a question of fantasy. What was the patient's fantasy, desire there?
Yeah, I think we're all like, we're all liable to the co-optation by any writer, right? I mean, we draw from, the people we encounter. I don't know that my students would, I've certainly written about students. I've never had them object to how I've portrayed their classroom comportment. I don't know what I would do if they did, but I guess they have the opportunity to write as well, and to write back as your patient did.
Yeah, that's a great.
All right, thank you very much. I sense the restlessness of our organizers over here. They're